All right, welcome everyone. Thanks so much for joining us today for our webinar focused on service and resource sharing approaches from a statewide systems lens. I'm Rena Chudgar. I'm the Senior Director of our Public Health Systems and Services team at the Public Health Accreditation Board, or FAB, and really excited to have y'all here to dive into this topic. Just wanted to go through a few logistics first to share with y'all on the next slide. A few kind of reminders here. We have everyone automatically muted. Please do utilize the chat box to engage with each other, to introduce yourself, and to enter any questions for our speakers today. Because we're doing a meeting, we will have an opportunity as time permits for folks to come off mute as well. But really use that chat box to engage, as that's how we'll be monitoring what questions and discussion to have as we go throughout our time together. We would again like to remind everyone, if you're able to and willing, to keep your cameras on if possible. We love to see all of you as we're sharing information, and then again to engage in conversation and discussion. And we are recording this webinar, and it'll be sent out in the follow-up email as well as posted on FAB's website. And want to also remind folks that closed captioning is available for today's meeting. It's within the Zoom, should you wish to turn that setting on. To enable them, if you click the CC button in the meeting toolbar shown in the screenshot here on the screen. And it may vary again, and its location may vary again, depending on what version of Zoom you're using. But somewhere on your screen, you should see a CC button, and if you click that, you can enable it for yourself. And if you click it again, you can disable it. Really happy and excited to share our speakers for today. Each speaker will share a little bit more about themselves and where they're coming from when it's up for their portion of the presentation. But thank you to Travis Parker-Lee, who's a senior specialist at FAB, Grace Gorenflow, who is a consultant with us through Gorenflow Consulting and a subject matter expert in service and resource sharing, Jeff Ketchel, who is the FPHS director from Washington State Department of Health, and Andrew Epstein, who's a local and tribal public health policy lead with Oregon Health Authority Public Health Division. So thank you all so much, and please feel free to share additional information about yourselves when you are up in the presentation order. And just to highlight our flow for today, we really hope to share and describe various approaches for statewide service and resource sharing, as well as specific examples for state and local health departments on how you might consider kind of thinking about setting up decision-making structures and then implementation around service and resource sharing within your state system. We're going to start with an overview of service and resource sharing and describe some characteristics for various approaches. Share some state examples from Washington and Oregon, share success factors, and then have Q&A and discussion. We'll actually have Q&A and discussion peppered in throughout our time together after our presenters go, and then some time at the end. So with that, I'm going to turn it over to Travis to lead us into providing an overview of service and resource sharing.
Thanks, Rena. I appreciate the welcome and introduction. So to help frame what we mean when we speak about service and resource sharing in the context of public health transformation, we do like to show this definition in all of our presentations. We did co-create this with states we work with, Washington, Oregon being two of them, along with those in the field that were able to provide feedback when we vetted this. I'm not going to read the definition verbatim, but I did want to highlight that we focus on reimagining the way systems are structured that advance health, well-being, and equity for all. We feel this should be done through utilizing the Foundational Public Health Services framework, but we recognize there are other ways to modernize and transform within this space. If you're not familiar with the Foundational Public Health Services, here is the graphic for it. The Foundational Public Health Services, or FPHS framework, defines a minimum package of public health capabilities and programs that no jurisdiction can be without. The framework was updated in 2022 to assure it reflects the evolving nature and modernization of governmental public health. So I'm sure you've seen different versions of it, but this is the current version that we are utilizing today. Again, the framework outlines the unique responsibilities of governmental public health and can be used to explain its vital role in a thriving community, can be used to help identify capacity and resource gaps, can be used to help determine the cost for assuring foundational activities, and then help with justifying funding needs through advocacy. You'll see here at the base, the framework starts with the foundational capabilities, recognizing the importance of building a strong infrastructure to support implementation of the framework. And then up top, we have the foundational areas and community-specific services, which are depicted as being supported by infrastructure. And then you'll see that equity encircles all the components of the framework, emphasizing its essential in all aspects of the FPHS. So we might be treading a little bit of water from a previous webinar we did in this series, but again, wanted to ground everyone kind of in our same language and understanding when we talk about service and resource sharing. So we define it as it occurring when health departments share insights, expertise, techniques, and tools across organizational boundaries. And these boundaries can include things like a population served, a specific service area within a state, or district or governmental jurisdictions. Sharing empowers public health departments to work together to protect and promote the health of the people they serve more effectively and efficiently. And by sharing those insights, expertise, techniques, and tools, health departments can accomplish a lot more than they could do alone. Ultimately, this enables a reduction in efficiencies and ensures services are delivered to citizens that need them most. And it also allows health departments to develop innovative methods and access services and resources during public health emergencies, in addition to helping prepare systems for the next public health threat. So through our work with state systems, we developed this graphic to taking a systems approach to transformation. You'll see at the top, we feel it starts with developing a vision and adopting a framework, hopefully the FPHS framework. Part of this step includes focusing on defining what that system actually looks like and means within the state, and then ensuring that the system is in alignment with where it sees itself in the future. Another component of this graphic is assessing the current landscape. So what is your current spending and capacity towards the FPHS? And you can determine this by using a tool like FAB's FPHS capacity and cost assessment. And we do encourage folks to do this using a systems approach and lens. So really looking across all health departments to get a comprehensive look at the system. After assessing, next is determining the gaps between your current state and then your vision state, and really building those relationships and advocating for sustained funding for public health based on your assessment and gap data. Then once you have all that information, you can start implementing approaches to transform the system and really build up and build out those foundational capabilities and areas. And this is where service and resource sharing and other models really come into play. All parts of this graphic are essential to sustained and strategic public health transformation, and all parts are actively working together, hence kind of the non-linear depiction of the graphic itself. So I'm not going to spend too much time on this slide, but again, I did want to ground us all kind of in the same way that we're talking about approaches. So there are three approaches that we've identified and outlined here. Today, we're going to focus on the first one, the state level system-wide approaches. So that refers to services and resources offered by a single centralized entity and or a state health department that has a strategy to promote arrangements among local health departments in the state. Some of this can look like a service or resource that's disseminated to all in the state, state health department or entity providing incentives that encourage arrangements. That entity or state health department funding a single local health department to provide a service for all in the state, or like a purchase service or resource agreements, kind of that one for all concept. And then we'll provide a link at the end of the presentation where you'll be able to access more information about this approach and then the other ones as well. So before I turn things over to our guest speakers, I did just want to highlight some decision-making characteristics These are from the Washington State Department of Health Shared Service Demonstration Site Project report. And again, we'll provide a link to this in the chat at some point during the presentation, and I'm sure Jeff will go over this a little more too. But I just want to highlight some of the ways to decide when services are good candidates for sharing. So something like an infrequent or sporadic need for services that costs a significant amount of money. For example, in surge disease investigations, and most recently that could be the COVID-19 contract tracers that were employed, or periodic community health assessment that need that specific expertise. Speaking of that, there are expensive or rare skill sets of expertise that may be needed that could be easily transferred or deployed in a time of need. And really recognizing that that doesn't need to be local to the jurisdiction, it can be provided from a distance. Additionally, there might be services with significant upfront capital and resource investment. For example, services such as higher quality labs for infectious diseases and online resource development require relatively costly upfront investment in technology to get those off the ground. Another example, services with little marginal cost to increase participation or expanding a service to additional agencies. We've seen video conferencing as an example that can serve more people at a pretty low marginal cost, relatively marginal cost, I should say. And then lastly, services that can be delivered virtually. Online and virtual platforms can be leveraged for information sharing, data collection, and other type of services with experts and other colleagues within your state. So with that, I'm going to turn things over to Jeff to kick us off for our state examples. Jeff, whenever you're ready, you can come off mute and start.
Thank you, Travis, and good afternoon, everyone. My name is Jeff Ketchel. My pronouns are he, him, and I am the Director of Foundational Public Health Services in the state of Washington. I've worked in public health in Washington for 30 years, including 24 years at the local level, and I'm excited to talk about shared services today. Next slide. So first, I'm just going to do a brief summary of what is the governmental public health system in Washington. It's a four-part system. It includes of course, the Washington State Department of Health and the Washington State Board of Health, but it also includes the 35 local health jurisdictions and the 29 sovereign federally recognized tribes. And the 35 local health jurisdictions are coordinated by WASALFO, which is the NACCHO affiliate here in Washington. And the 29 tribes are coordinated, but not represented, by the American Indian Health Commission that works with us in helping us connect FPHS with the tribes. Next slide. Okay, so what is FPHS in Washington State? And so in 2019, our legislature passed a bill putting FPHS into statute, and a couple of important things. One is it created a concurrence process, meaning that all four parts of the system had to agree on allocation of funding and what projects specifically to be funded. But also in looking at the second bullet on the first one, it directed us to implement service delivery models, allowing for system stabilization and transformation. And in the glossary, it defines service delivery models essentially as shared services. Next slide. Just roll through this, Travis. So in Washington, how we define foundational public health, so they're population-based, something that no matter where you are in Washington, in a city, unincorporated county, or on tribal sovereign land, it is available. Most importantly, it is unique to governmental public health, and it also includes services that are mandated. For example, in Washington State, it is mandated that at the local level, not only is tuberculosis surveillance and investigation required, but also culturally appropriate treatment for active TB as well. Next slide. And this is just a quick structure of our FPHS in Washington. Notice the four parts coming together to run our steering committee with our support staff and project management team. Each of the capabilities and foundational program areas have their own subject matter expert work groups. And I talk about this more specifically in that it is not a top-down organization in Washington. The 4 parts work together jointly. Like I said, all 4 parts have to agree before our Office of Financial Management will release money for distribution. And so all decisions are made through consensus. And so if there is a proposal to add a shared service, this is something all 4 parts have to come together on and find agreement with. Next slide. So resource sharing. And so as we were designing resource sharing originally in Washington, these are the things that were guiding us. Again, this concept supported by all. So nothing is top down, but also includes at the local level, if multiple jurisdictions or tribes wanted to partner together for a service, nothing is there preventing that. The access to specialization, I'll talk a little bit more about that, but one of the examples of a shared service is around TB investigations and support, in that some jurisdictions might see an active TB case but once every 10 years. And so when one does surface, they just don't have the regular experience to do so. And Public Health Seattle and King County, our largest jurisdiction in Washington, it provides that service. The ability to hotspot. When I was a local health district administrator, we shared a communicable disease epi with amongst 4 jurisdictions. And so when I was the epicenter of a multi-county Q fever outbreak, she came and spent 4 days a week with me at our office, helping out with that. And then when E. coli outbreak happened in a neighboring county at a childcare, she hopped over there and she had the ability to hotspot like that. Customer satisfaction. If our steering committee is going to allocate funding for a shared service where one entity is going to provide services over multiple entities, making sure that those multiple entities are getting that expected level of services. Next slide. One of the things that guided us along the way was understanding the spectrum of shared services, and this was at the time from the Center for Shared Public Health Services. Back when I started this journey, I saw regionalization as the only shared service, and was happy to learn that there's many steps along the way, from informal to more formal, and we definitely take these approaches, and it's not a one-size-fits-all. Next slide. So from this work, we developed an algorithm looking at effectiveness and efficiency. And these are 2 of their statutory requirements in the FPHS state law. Next slide. So first, I will talk about effectiveness. That's the graphic on the left. And so on the y-axis is highly specialized expertise. On the x-axis is local presence. And so in looking at our definitions, if something really commands a local presence, like I use that example for community mobilization, a lot of this is political engagement, coalition participation, or coalition building. That should really be local. That's not something that can be done either regionally very well or from a neighboring jurisdiction. However, if something does require highly specialized expertise, I use the tuberculosis example. Of course, epi and things around informatics and things like that, then a shared service makes more sense. Not every jurisdiction needs, program evaluation expert. And so those are the types of things we look at. At the rural level, people tend to be more generalists, as they often wear multiple hats. At the more urban and larger jurisdiction level, people are able to become more specialized, and so find that balance. And then, of course, if it's neither, then it depends on the situation. Next slide. And then looking at efficiency, on the y-axis is capital intensive. On the x-axis is labor intensive. So, for example, in Washington State, we have basically one state public health lab, though Public Health South King County does have some lab capacity. And so that is something that is highly centralized because of the capital costs involved in that. And so that should be shared, but of high labor intensity field work. And so like for restaurant inspections, if you're going to have, share food inspectors for multiple jurisdictions, you're probably going to spend more of your resource paying that individual to drive than you are going to be paying them to inspect, and that ends up becoming a less return on investment. And so things that involve field work, it really makes more sense to make that local as much as you can. Next slide. And then we produce I know it's very hard to read this. I'll put the link in the chat to this report. So every year, our fiscal year is July through June. And so every year we produce a assessment report of what's going on FPHS in Washington. And since our state law directs us to look at service delivery, we asked 2 questions. This is the question: willingness to receive FPHS. Next slide. And willingness to provide FPHS. And I would say over time, there has been a more welcome position amongst the entities to receive shared services, which is a great move, because in the early stages, I'd say there was a little bit uncomfortability around it. Next slide. That's it for me. Thanks, Travis. Thanks, everybody.
Thanks, Jeff. Really appreciate you sharing what's happening in Washington around service and resource sharing. Did want to take a pause to see if there are any questions specific for Jeff and or the work in Washington. We'll just take a couple minutes here to see if anyone would like to either put it in the chat and we can read it, or if you want to come off mute and put your camera on, we can ask live questions as well.
Okay, so I have some questions.
Of course you do, Grace.
Of course. Jeff, I love those the boxes that you all did, the graphs. That's super helpful, and thank you so much for sharing your report. I'm wondering if you know of any sharing that is occurring between tribes in your state.
Not at this point, but every month we have our 29 tribes meet with American Indian Health Commission and Department of Health staff to talk about their work in FPHS. In Washington, each tribe is receiving $200,000 a year for culturally appropriate FPHS, and one of their deliverables is to participate in these meetings. And shared services has come up. In fact, I've done a very similar presentation for them on this topic, and we've had conversations about that, but also shared services between tribes and local health jurisdictions. And so there's a lot of interest there. We're currently pursuing increased funding to provide more money for tribes, as now their platform is strong and they're ready to expand up. And I know shared services is of great interest there.
Okay, great. I know that Washington State, as part of, I think it was part of your transformation efforts, you can correct me on that, had a number of pilot projects that they supported at least a couple of years ago. And I'm wondering if you could tell us a little bit more about TB and how you all approach it. I think that's a great example. And then also, do you have any current pilot projects that you all are working on?
Yes. So the TB project, I think I mentioned it briefly. Public Health in Seattle King County provides technical expertise to jurisdictions that need it because of an active TB case, and that's a range of things that are available, from contact investigation and interviews to more. And so that is an ongoing funded project. The project definitely needs more resources, as do most of our projects. Unfortunately, over time, with flat funding, it becomes less funding with increased costs. And so that is definitely an area that needs to be beefed up. And then some ongoing shared services. One, Tacoma Pierce County Health Department is designing and has designed and implemented healthcare interface web pages for many local health jurisdictions, where if you're a clinician in a jurisdiction, you go to your local health department website and you can get all the information you need regarding notifiable conditions and sign up for health alerts and things like that. And so a number of LHJs have that, and that was designed by Tacoma Pierce County. And then we also have language lines in Public Health Seattle and King County. There's some 40 or 50 languages spoken in King County. And so they have created a language line where I think it's just 8 jurisdictions right now can call in and get interpreter services from them with somebody who has some knowledge or expertise in public health, which is very helpful. So every jurisdiction doesn't have to staff all the possible languages that might walk through their door. And that is also one we would like to expand, because there's many other jurisdictions that would like to have access to it. So they're victims of their own success.
Indeed. All right. There's a question in the chat box. What service or type of service has been shared the most between different entities?
I mean, the shared epidemiology has been a more popular one. But as you know, Foundation Public Health Services has expanded. I'm definitely not an epi person, but you know, there's different specialized skill sets within that world around assessment, evaluation, communicable disease, and things like that. So being able to share the more specific specializations as well, because it's often not a one-size-fits-all situation.
Great. Okay. And another question for you. Thinking about the matrix that you shared, does that pretty consistently hold true between metro or more resource counties and more rural counties? Or do you see any kind of a difference in terms of what is best done centrally versus decentralized?
I mean, generally too, because it makes sense. You know, as former local director, I wouldn't want somebody from another jurisdiction handling community relationships and politics on my behalf, because they just don't have that credibility. They don't have those regular relationships, and so that.
We may have frozen or bad internet on Jeff's side. We'll give him just a couple seconds.
Is that better?
Oh, there you go. Yep, you're back.
Sorry about that. I mean, there was this thought at one moment that all services could be shared, and we definitely know that's not to be true. And so, trying to break down what makes more sense to be shared or not shared. I mean, obviously, as a rural jurisdiction, I had a neighboring jurisdiction that lost entire environmental health staff within a couple-week period, and they asked us to share services for septic inspections, and that was very expensive for us to do that for them. I mean, they had to pay the full freight of it, but they moved very quickly to hire somebody because it was undue for them. So that expensive field work and drive time is a big deal.
Great, thank you. And then it looked like you just collected quantitative data with respect to those who are the areas where health departments were willing to share for, provide for another or receive from another. I'm wondering, so I don't know if you've collected any data on more of a qualitative basis. Do you know, can you speak to any of the hesitations that are involved, especially when it comes to rural areas?
Well, I mean, before the sizable investment in Washington State, the hesitations were based on scarcity, where just give me the money and I will decide if I want to share services or not, because resources are just so thin. I'd hate to see money go somewhere else when I need every penny to save all my FTEs. Now that there's a sizable investment, I think there's a greater comfortability with it. And there's more exploration between leadership all over the state and trying to find ways to maximize the resources they have. And there's I think some a little bit less turfiness out there.
Great. Thanks, Jeff.
All right, I'll do one last call for questions, either in the chat or if folks want to come off mute. And also, this won't be the only opportunity. We'll have a bigger or more time at the end for Q&A discussion as well. So, all right, I'll go ahead and turn things over to Andrew from the Oregon Health Authority Public Health Division, if you want to go ahead and get started.
Thanks, Travis. Good afternoon. My name is Andrew Epstein, he, him pronouns with Oregon Health Authority Public Health Division. I've been with OHA for about half as long as Jeff has been with Washington State. So I've been here for 15 years, working at the Health Authority. Less than that, more like 3 or 4 years in my current role, which is managing our public health modernization funding to local public authorities and tribes throughout the state. And just to kind of get you grounded in Oregon's model, we are a decentralized public health system. We have 33 local public authorities around the state, or LPHAs. Each LPHA generally is a county government. There are 2 counties that have come together to become a public health district. Every LPHA is a county. There are also 9 federally recognized tribes. And more recently, we've added CBOs, community-based organizations, as partners that we fund for modernization work as well during the past few years. Next slide, please. So we started our journey to public health modernization about 10 years ago. We developed a framework for modernization, which actually is in statute. Similar to the national framework that you've seen earlier in this meeting, we have foundational programs, foundational capabilities, and we were fortunate to receive funding, state general fund investments starting in 2017 to 19 biennium, $5 million in funding for that biennium. Some of those funds went to the state, to OHA. Most of those funds went to LPHAs. And because the funding amount was kind of minimal, we decided at that time to give all the funds towards regional efforts, feeling like the money could be better spent at that level if there are regional projects, rather than trying to divide that small amount among all 33 LPHAs. The next biennium, we received an increase in total investments. $7.3 million went to individual allocations for LPHAs. $3 million went to the regional allocations. 21 to 23, the amount continued to increase. Some of those, you see the amount that went to LPHAs. The amount for regional allocations stayed fairly constant, while the amount for individual LPHA allocations increased. And where we are today, we have even more funds. Luckily, we have funds, funds to allocate to LPHAs, tribes, and as I mentioned, now CBOs are receiving modernization funds. And we work closely with our statewide group of LPHA leaders, which is called CLO, the Conference of Local Health Officials. And in consultation with them, they determined they wanted to keep the regional allocation level pretty much flat funding, except giving a 10% increase for inflation for this current biennium. Next slide, please. So here you can see a map of the current regional partnerships. And you can see that most of the state is covered by a partnership. There are some counties that opted not to participate, and this is completely voluntary. Self-forming regions, LPHAs come together based on shared interests and needs for working with neighboring counties. I'll talk more about some of the barriers for why some may not have participated later in the presentation. The regions do the same focus areas as LPHAs are doing under their individual allocations for the LPHAs. So we have a document called Program Element 51, and I'm just going to put that into the chat so you can check that out later if you want to. So the Program Element 51 is the document where we basically state what's required for LPHAs who are receiving this modernization funding. based on legislative priorities for how the fund should be used. So currently, funding prioritized foundational programs of communicable disease and environmental health, with the environmental health focusing on climate adaptation. Also, the work looks at advancing foundational capabilities around health equity, community partnerships, communications, whatever it needs to be addressed within the specific jurisdictions. There's another document which I shared in advance with Travis, which has, actually, would you mind sharing that, Travis, or whoever's sharing the screen, to switch to that other document?
Let me go ahead and pull that up.
We'll give you a little more information about what we asked for LPHAs that are submitting proposals. Again, this is completely voluntary. LPHAs can apply for to be a region if they want to, but it's not required. So if you just a little bit, make it a little bit bigger. And then this is the proposal that we asked LPHAs to complete. There's a one LPHA serves as a fiscal agent for the entire region that's proposing to receive this funding. So if you scroll down a little more, keep going. So the three options, so basically there's regional partnerships, and then we talk about when that might be useful. So scroll down to the next page, please. So this is if there is ongoing coordination across counties that share our population, geographical boundaries, or shared health system, or long-term planning with the community partner that partners with the LPHA, group of LPHAs. Option 2 is regional staff. If there is a desire to have a regional specialized position to provide coordination across 2 or more LPHAs, and examples for when this may be beneficial, as noted, is hiring a shared position when individual LPHAs cannot fulfill the specific need due to the amount of work that would be required for the need. And if there's a need to hire regional staff to provide a service for more than one LPHA. And the third option is a regional project, which may be limited in duration or may be ongoing. And examples listed here is projects across a region, like a regional communications campaign, health equity, or all hazards climate adaptation plans, providing a service across multiple counties. So let's go back to the PowerPoint slides, please. Thank you. So that's just a little bit of grounding into like how LPHAs come together, why they come together. So as you see in the map here, 25 of Oregon's 33 LPHAs have chosen to participate in a regional partnership. You go to the next slide, please. So back in the last biennium, 2021, 2023, we did some progress reporting. We don't have more current data because we're right now doing our progress reporting for this biennium. We'll be receiving that from LPHAs on Friday, actually, for those who are on time. So, but we can share what we heard from LPHAs last round. So we asked them to describe how regional resources are contributing towards LPHA's planned modernization work. So here are some things they mentioned around building equity and community engagement into all aspects of their data cycle. One group of LPHAs worked on a regional data mart. We're kind of looking at data collectively to meet their specific needs for their region. Shared positions, and that included epidemiologists, climate and health coordinators, health equity coordinators, congregate setting outreach nurses, modernization coordinators, health educators, communicable disease investigators. Those are all positions where each LPHA as an individual county, based on their funding, they couldn't really support those positions by themselves, but collectively as a region, they could then fund that kind of staff to meet that region's needs. Developing sustainable infrastructure for a regional health improvement plan and leadership development efforts. Next slide, please. So this slide is kind of similar. We just asked fiscal agents for each region to talk about their activities in progress towards the regional project or partnership. They described their progress that they made on health equity assessments and plans and climate and health work. They talked about rebuilding infrastructure for regional partnerships around community health improvement plans and community health assessments. They described regional staff that had been hired to support the individual LPHAs as well as regional efforts, improvements in the regional data mart. One region had a communicable disease task force that was very active, and another region had a on-call after-hours reportable disease line and hired a regional public information officer to support that work. Next slide, please. So currently, we require that these regions consist of at least 2 LPHAs. In most cases, it's more than 2. We also have encouraged partnering with others, not just LPHAs, so others outside of the governmental public health system. And those partners have included coordinated care organizations, which are health systems, local governments, healthcare organizations, CBOs, coalitions, tribes, Oregon Health Equity Coalition, which is one of our regional health equity coalitions in Oregon. And another region talked about having a steering committee, which included the CCO with coordinated care organization, too many acronyms, regional health system, United Way, and having various work groups with other partners represented. Next slide, please. So we asked in that reporting, we asked the partnerships to share what was going well, what were the benefits of participating in these regions. What they shared is having stronger connections across LPHAs. So neighboring counties tend to work together and network about their work, but this kind of required a more in-depth level of coordination than they would have done otherwise. Stronger, more relevant supports for rural counties. Rural counties, I think, especially benefited from some of the regional work. Building infrastructure for more cross-jurisdictional sharing, shared and reduced costs for regional efforts such as community health assessment and improvement plans, increased recruitment pool when you're looking at hiring a regional staff versus just a local public health staff, and partnership with regional health equity coalitions strengthened community engagement and collaboration. Next slide, please. We also asked them to share the costs and challenges of participating in these regions and what was not working well. What we heard is there were some challenges around communication and coordination across counties. So they're neighboring counties. They don't all do business the same exact way. So kind of working out some of those details was a little challenging. Travel costs, especially in more rural parts of the state where the distance even between neighboring counties can be quite far to travel. Limited capacity and delayed processes, and LPHA staff turnover, which was especially challenging during the earlier years of this work over the past several years during the COVID-19 pandemic, that we saw a lot of issues with LPHA staff turnover, as I'm sure you all saw in your jurisdictions too. Next slide, please. We asked those LPHAs, 8 LPHAs who reported not participating in partnerships, regional partnerships, why did they choose not to participate? So what we heard was 3 LPHAs said that regional focus detracts from local priorities. 2 LPHAs said that there was a lack of local capacity or funding to participate in these regional efforts, because although there is funding to the fiscal agent, it does require some degree of funding from each jurisdiction to be part of it as well. Lack of support from commissioners or agency leadership, that was what one LPHA said. Another said there were no natural partnerships with other counties, and some other comments that people shared was lack of support and capacity due to constraints from COVID-19. Past regional efforts were concentrated in urban centers, and that was a county that I think was more interested in working at the rural settings. Lack of county leadership support for climate adaptation planning, which was a focus for the region that that county might have been part of with their natural neighbor county groups. Physical size of county and distance between county seats, and I think in one case a county contracted with another organization to provide public health services, so they didn't feel like participating in a regional partnership would be beneficial for them. Next slide, please. So that's my contact information. If you, there's a link that web link goes to our Public Health Modernization of LPHAs and Tribes webpage, which has the program LM51, which I put in the chat earlier. So if that will take you to that, as well as many other resources we developed for individual LPHA and regional modernization efforts. So check that out if you're interested. And there's my contact information. Happy to answer any questions for states that are considering developing a similar model as we've developed here. Thank you.
Thanks so much, Andrew. Really appreciate that, and really showing how your state is putting money behind the sharing arrangements. And I see Sarah Boudreau on. Good to see you. One of our contacts at the state as well. Just want to give space for if there are any questions for Andrew or Oregon's approach to sharing services.
So, Andrew, every time I had a question, the next slide would answer it. So you're off the hook for now, but I'm glad you shared your contact information, because as I digest this, I'm sure I'm going to have more questions. I would just say this is, a phenomenal effort, and I learned a lot from the slides, and I think we can learn even more as we dig a little deeper. So,
Thank you.
Yeah, sure.
I did have a quick question. So you did mention kind of that reporting piece for the partnerships going back to the state. So just curious about kind of that accountability mechanism to make sure, or to ensure that all the system partners are really like kind of working together to share, especially with that slide you had up of the non-LPHA folks. It's a lot of people involved. So just want to know how you kind of ensure that sharing is happening while you're providing that funding.
Sure. So we require each fiscal agent for the partnerships to submit a work plan and a budget telling us how they're going to spend those regional funds. And we ask that they develop that collaboratively with the other LPHAs within the region. And for the progress reporting, we do that once a year, basically. The fiscal agent has to report on progress towards their work plan goals for the region and whether things are going as planned. We also ask the other LPHAs that are participants, but not the fiscal agent, to also do some degree of reporting of whether it's going well with the region. So if hopefully if an LPHA that wasn't the fiscal agent had a concern, like we would hear about that through their reporting as well. But those reports that are done annually are the main mechanism for kind of hearing how things are going. And of course, we also monitor budgets to make sure that the budgets are on track for LPHAs spending the funds that OHA awards through our public health intergovernmental agreements. Does that answer your question?
It does. Thank you.
Sure.
And see if there's any other questions either in the chat or, oh, Sarah, I see your hand is up.
Thanks, Travis. Hi, everyone. I'm Sarah Boudreau. I use she and her pronouns, and I'm with the team here in Oregon. And, I've been listening to these presentations, which were great, and reflecting on some of what Travis shared at the beginning about how service and resource sharing is really like a critical pillar to foundational public health services work. And that's kind of what I'm walking away with. Much like Jeff talked about the governance structures and decision-making structures that Washington State has in place, Oregon has similar sort of governance through our state's Public Health Advisory Board for bringing all partners together to guide our work. And that group has been talking for years around how to kind of balance what can feel like a tension about we're trying to move the entire public health system forward in Oregon and to have kind of a standard in every area of the state for what public health is, while also recognizing that our counties are extremely different. We have very frontier counties as well as very urban counties, and the way that they need to structure and set up public health is so different. And I think service and resource sharing and how counties work together to make sure that services are available everywhere is just a really critical piece. So I think Oregon is, solving one piece. I think there's a lot more work to be done in sort of exploring different models of how public health can be organized and how sharing can happen between different types of organizations to kind of get us to that ultimate outcome of a standard level, a really good quality level of public health available in every area of the state. I actually didn't have a question. I was just sort of reflecting on what I've been thinking about listening to these presentations today.
I appreciate reflections as well. Thanks for sharing that, Sarah. Jeff, I see your hand is up.
Yeah, I'll just say briefly because I see a question, and I just want to acknowledge Marie Flakes in the audience, and she was there at the beginning of FPHS with me back in 2011 here in Washington State. So hello, Marie. And Marie reminded me of a couple of things that I have forgotten, and that was in the early days here in Washington, shared services were some of the earliest investments that we made, knowing that was really a political and legislative priority, but also made a lot of sense. And so, and I just remember it being a very tough sell, because what I described before was just a time of scarcity, but it was the right call. Things like investing in more BRFIS data for rural jurisdictions, so we have a better sense of what's going on. Of course, the TB one, training for data camp for EPIs and things like that. So anyway, thanks.
Thanks so much, Jeff. Really appreciate you both states sharing about the great state and local collaboration that's happening and really getting the service and resource sharing work underway. I did miss a question in the chat. I'm sorry about that, Sylvia, but a question for Oregon. So how is funding determined equitably between the regions? So I don't know if Andrew or Sarah wants to answer that.
Good question. As I mentioned, regions could self-select if they wanted to be part of the specific region. And there was a total pot of money in this current biennium is $4.4 million. We actually decided to continue this biennium, what was in place last biennium, if there was interest. So previous to then, LPHAs could just self-select a group and apply for the amount of money that they wanted within the total pot. So I don't think we had really a role in determining that equitable funding for the regions. Sarah was actually led that initially. So Sarah, do you want to add anything to that? Back when this started?
I don't think I have anything particularly useful to add.
And I think we were pretty much able to meet each region's request. We had to reduce somewhat some of their requests because if it was like more than total pot of money, but we were able to kind of keep it proportionally similar for the most part to what they said they needed.
Great.
And we feel like pretty satisfied, I think, with the spread around the state. It seems like it's covering, just based on that self-selection, is covering the areas where we might expect to see more geographical, like rural health disparities, for example. So it seems to work pretty well.
Thank you for answering that question. Appreciate it. Well, recognizing that we have about 6 minutes left, I want to do just a little bit of more content that we had. So I'm going to turn over for Grace for just a minute or so, and then see if there's any last minute questions before I close with just a couple of items. So Grace, I'll give it to you just for a minute.
Okay, great. We do have a couple of resources in particular. One is state guidance for sharing public health services. And you will see reflected in here a lot of the principles that were reflected when Jeff and Andrew were giving their presentations. I would also mention that there are two ways to think about states' involvement in sharing agreements. One is to set up the kinds of funding opportunities that they have to promote this. And another is when states aren't necessarily doing anything in particular to support sharing arrangements. However, they are happening at the local level. So we have suggestions and guidance in there for both of those scenarios. And I'm just going to echo something that Travis said about state and local collaboration. That's one of the keys to all of this, and these states have done a beautiful job. Especially, I appreciated Sarah's comments along those lines too, that it's very clear both of these states have done a beautiful job as far as that goes. And then the other piece that that we wanted to draw your attention to was our success factors. And the success factors are true and helpful, we think, regardless of how a sharing arrangement has come into play. And they really, in addition to, and I'm not sure how much state and local collaboration is in there, but it really also speaks to something that Sarah said or sort of hinted at, that things are so different, as you all know, in a state in terms of what happens at the local level and what different communities and counties look like. And for that reason, it's so important for the locals ultimately to be the ones who make decisions about who they partner with, if specific partners need to be selected. And so our success factors really speak a lot to those kinds of arrangements. And there is a link that's been put in the chat box for these and other resources that Fab Center for Innovation offers. So that's all I wanted to say. Travis, I'll turn it back to you.
Thanks so much, Grace. Recognizing that we are almost at time, and I know that Jeff and Andrew have to hop to another meeting right at the top of the hour, we'll go ahead and let them disconnect when they are able to. And if you have any questions for them specifically, put them in the chat, or you can reach out to us and we'll make sure we'll get them to be answered. But yeah, in our last few minutes, I did want to share just a couple of last minute things on how Fab can support your capacity building needs. So we are able to assist with service and resource sharing strategy implementation, consultation, and implementation. We can work with you to provide guidance on statewide strategies for transformation that includes service and resource sharing approaches like we discussed today. And then we've mentioned this before, but we can provide support with the Foundational Public Health Services Capacity and Cost Assessment, the Public Health Workforce Calculator, and other tools for transformation that we host, all through a service and resource sharing lens. And then specifically, if you are a FIG recipient, you can leverage those funds for technical assistance that support your service and resource sharing efforts as well. But just feel free to reach out to us. The email address is here on the screen, and we'd be happy to discuss your needs.
I have one more plug to make.
Oh, go ahead. Yep.
Oh, you were just going to make it.
I'm pulling in Andrew and showing the next slide that has your question. But as Grace shared already and what's been shared in the chat, we do have a host of resources available on our website, fall under the categories of some general tools for service and resource sharing, specific assessment tools, and then sample agreements. But then we also have several success stories on how public health entities have collaborated to enact sharing arrangements and agreements that have improved health outcomes. We do hope you utilize those resources and read the stories, and we hope they are helpful in all of your work that you do. We'll put this in the chat, but the website, or I think it's already in the chat, the website to access all these resources. But then also we're constantly collecting examples from the field. So if you have a service and resource sharing example that you would like to share with us, you can use this link to fill out the form, and we'll get in contact with you to talk a little bit more about that, and possibly turning it into a story. So we're right at time. I want to thank you all for joining today's learning session, and a big special thank you to Rena, Grace, Jeff, and Andrew for speaking and sharing. We hope today's session was informative to help support your work. And please be sure to connect with us on all of Fab's social media accounts. The usernames are there. And then lastly, we invite you to provide feedback using the evaluation link posted in the chat, or by scanning the QR code here on the left. The feedback provided about today's session will provide us with valuable insights to inform future learning sessions. And if you aren't already signed up for our e-newsletter, you can use the QR code to the right to quickly be added to our distribution list. With that, thank you again for your participation today, and you may now disconnect. Bye, everyone.